Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
I am Isabel Olivera, a medical writer at the European Hematology Association. Welcome to this podcast on precision medicine and myelodysplastic syndromes. I have the pleasure to have here with me today Professor Maria Teresa Voso. Welcome, Professor Voso. Can you please introduce yourself?
Good morning. I am Maria Teresa Voso and I am a professor of hematology at Vergata University in Rome, Italy. My main interests are diagnostics and treatment of myelodysplastic syndromes and acute myeloid leukemias.
Well, thank you for being with us today. To start off, can you please explain briefly what are myelodysplastic syndromes, MDS?
Myelodysplastic syndromes are disease of elderly patients, and they are usually characterized by peripheral blood cytopenias, most frequently anemia, dysplastic changes in the bone marrow, and increased blast proportion, especially in the higher risk subtypes. They're also frequently associated, as we know now, with karyotype abnormalities occurring in about 60% of cases, and somatic mutations in myeloid genes, which occur in about 95% of cases.
So, we talk about precision medicine a lot now. Can you tell us what the role of precision medicine in improving diagnostic accuracy and early detection in MDS is?
Yes, so precision medicine plays a significant role in improving diagnostic accuracy in MDS. Indeed, following the large-scale application of NGS technology, the diagnostic path of MDS has been improving, especially in cytopenias of unknown significance, for instance, neutropenias, which we as hematologists often see in our outpatient clinics, where presence of one or more mutations in myeloid genes at higher variant allelic frequency is associated with a significantly higher probability to develop a myeloid malignancy, including MDS. So targeted gene panels are nowadays largely available for MGS and include a variable number of genes ranging between 30 and 60 genes. These tests can be performed in peripheral blood samples and have a high clinical relevance to schedule, for instance, follow-up studies. So a patient with no mutation may not need to undergo a bone marrow aspirate every year, as we did in the past, while patients with mutations at higher risk of developing a myeloid disease may require more frequent follow-ups. Cytopenias of undetermined significance characterized by the absence of morphologic signs of dysplasia and of karyotype abnormalities have been included in the new classifications of MDS, the 2022 WHO and ICC classification with or without a clonal marker, and are defined as ICOS or CYCOS, so cytopenia of undetermined significance with a clonal marker. And in this context, I would like to mention a new disease which has been recognized in 2020, and this is VEXAS. It is a new X-linked syndrome, frequently characterized by anemia, vacuoles in the hematopoietic progenitors in the bone marrow, somatic UBA1 gene mutations, and autoinflammatory symptoms. This is a disease which needs to be identified. It accounts for about 1% of MDS, and this has been shown this year at ASH by IWG, looking at the prevalence of UBA 1 mutations in a large cohort of MDS patients. And it is a disease at the border between hematologists and rheumatologists due to the autoinflammatory symptoms. And it's important for MDS because about 60 to 70% of VEXAS syndrome present as MDS.
Can you summarize the new classification and the role of germline predisposition in MDS?
Yes, as we know, 2 new classifications of myeloid diseases, including MDS, have been published in 2022, the WHO and ICC classification. And in this context, precision medicine also plays a role. And indeed, in addition to karyotype and morphology, the type of mutated genes also plays a significant role in classifying the disease. And among disease-defined abnormalities, 5q minus is an old recognized MDS subtypes. But in addition to this, SF3B1 mutations are disease-defining for MDS with ring sideroblasts, and TP53 mutations define the new TP53 mutated myeloid neoplasms, including MDS, according to the blast proportion. Some other genetic aberrations are important to exclude specific for our exclusion criteria for specific categories. For instance, abnormalities of chromosome 7 in 5q minus MDS, or complex karyotype, or abnormalities of chromosome 3, 5, or 7 in SF3B1 mutated MDS. Germline predisposition plays a significant role in MDS as well, and this has been recognized again by both the new 2022 classification as before in 2016, and most myeloid panels include some of the genes whose mutations may be germline. But I would like to mention one which is frequent in MDS in about 3 to 4% of cases, and these are the mutations in DDX41 gene. DDX41 breaks a little bit the rule of germline predisposition, which is usually associated with disease onset at younger ages. In the case of DDX41, age at onset is usually 60 to 70 years old, and onset is associated with acquisition of a second hit of a second mutation of the gene. And inclusion of this gene appears mandatory in myeloid panels, in future myeloid panels.
So now that you can test all these myeloid panels and you have refined the risk stratification, is this being translated into more personalized therapies? What are the current targeted therapies available for MDS?
Yes, as you mentioned, gene mutations are now included in prognostic scores, the IPSS-M in particular, and the IPSS-M is useful to direct treatment approach and to define lower and high risk MDS. Of course, this is particularly relevant in the context of low-risk MDS, which, due to the application of the IPSS-M score, can be upgraded. And this could be a criteria for address treatment choices, including allogenic stem cell transplantation in younger patients. But the identification of myeloid, of genetic markers, is the base for the application of targeted treatments in MDS as well. And we have nowadays the almost historical lenalidomide, which is indicated for 5q minus MDS, and more recently luspatercept, which has received an indication due to its preferential activity for MDS with ring sideroblasts, which are characterized by SF3B1 mutations in over 80% of cases. The latest data presented at ASH on the COMMANDS trial, which is a phase 3 trial showing that luspatercept versus erythropoiesis stimulating agents is associated with significantly higher probability of transfusion independence in patients with lower risk MDS, all subtypes, and achieves responses of about 60 to 70% of the patients, and these responses are long-lasting. Actually, we don't have other drugs with a specific molecular target approved in Europe. However, among promising agents, I would like to mention imetelstat, a telomerase inhibitor, first in class, which has shown efficacy in the phase 3 IMerge trial in lower risk MDS with anemia, with transfusion independence achieved in 40% of patients who were relapsed or refractory after first-line ESA. For all these drugs, high transfusion burden is significantly associated with decreased responses, indicating the need for early treatment start in patients with transfusion-dependent anemia. There are several others ongoing phase 3 trials or some which have been recently closed where we are expecting results, and these include oral formulation of azacitidine or decitabine, and especially in higher risk MDS, the combination of azacitidine venetoclax has been tested in the Verona trial, and we are expecting results of that this year.
You have not mentioned any immunotherapy, no? So is there a path for immunotherapy in MDS patients?
Well, a lot of agents acting on the immune checkpoint, the immune checkpoint inhibitors have been tested in MDS, especially higher risk MDS, but actually the results did not meet the expectations, let's say, and some of the trials have been stopped, or the phase 3 did not confirm the phase 2 data.
You have given us many possibilities that are being used now, but can you please highlight the unmet needs that are still there?
Yes, as I mentioned, there are several possibilities available for anemias in MDS. I think one unmet need is other cytopenias, such as thrombocytopenia or neutropenia. These are a low proportion of MDS patients, but we don't have specific agents for those. Hopefully, the oral formulations of hypomethylating agents will show activity in that setting. But I would say a big unmet medical need is the context of azacitidine failure in high-risk MDS. And I would say the high-risk MDS subgroup overall, where the only drug approved in the last, let's say, 15 years has been azacitidine.
So in order to summarize for a general hematologist, the management of an MDS patient at the moment, what would be your key takeaway message?
Well, I think one should try to define the disease at the best of the possibilities and available methods. Of course, a younger patient with MDS should be screened for karyotype as all MDS patients, but also for somatic mutations to make the best treatment choice, including indication for allogeneic stem cell transplantation, and molecular profiles should also be used when available, also in older patients, to be able to use the newer targeted drugs. And also, not last but not least, also because we need real-life data, and collection of these data due to or thanks to working groups has helped to better define the disease and risk stratify the disease, and this is a very important possibility that we have, and we should try to use it as much as possible.
Thank you. Is there anything else you would like to highlight now for our audience?
Well, I think that MDS, the way I see it, it is a puzzle. It is a very heterogeneous disease, as you also mentioned before, and we are characterizing different subtypes, and so we should, in the past, in the next future, try to identify the subgroups as much as we can, because this is the key for stratification and treatment indication.
Thank you for this very insightful conversation. A special thanks to you, Professor Voso, for generously sharing your expertise and your time. And thank you all for tuning in and listening.
Thank you for this opportunity.